be able to just run it from
that way.
That
Okay,
way.
fine. All right.
In which case we're relying on Wi-Fi, which isn't great,
But is the video working? Can I just check?
just check if it's up there.
Okay.
Use it like normal. Just don't.
Okay, it's not my turn yet, so I don't save it anymore.
I don't think you can. So I would leave this open. Are you first or second?
Third.
So I'll minimize it. I'll leave it down there, and then just so you know what to open when.
Now, which token is Gustavo?
Harder.
And then?
And then Gustavo.
And then Gustavo.
And then we go back to programs. So echo and then our brain.
I'm gonna leave my email open here.
In 30 minutes.
I mean, you can.
Is this the next one?
Yes.
So,
And then
no, I would you show me again?
Sorry.
once again. Yeah. Okay, thank you for coming back. We have one more lecture from the cardiac session from the mid-trimester. So, Michal.
Okay, I will talk about something else. It's my third love. The first, my wife. The second, the brain. The heart, the third. So, I will talk about the very, to me, important sign of the fourth chamber, cardiac asymmetry. But I will start from the normal heart. This is the fourth chamber view, symmetric, left ventricle, right ventricle with moderated band, the crux, left atrium, right atrium, atrial septum, descending aorta, pulmonic vein, the long axis, left ventricle, aorta, right ventricle, left atrium, and right atrium, main pulmonary vein, artery, left and right pulmonary arteries, aorta, superior vena cava, the short axis, pulmonary ductus and right pulmonary artery, and aortic valve, and three vessels, the standard planes of the heart, but I think it's not enough for examination of the heart, just static pictures. I think it's much more better to look on the heart, on the life, with clips, And you can see here normal for chamber at 22 weeks. Slow, the same, slow left ventricle, right ventricle, normal opening of the valves, normal movements of the ventricle septum, and crossing between great vessels. This is images of pulmonic veins by slow flow imaging. It's very good choice for examination of the pulmonic veins. You can see here 2 pulmonic veins entering into the left atrium. The long axis view at 22 weeks. Normal opening of the valve, aortic valve, normal movements of the valves, tricuspid and mitral, normal movements of the septum. The short axis at 22 weeks, normal valve, the same on the slow motion, normal opening and closing leaflets, main pulmonic artery, left, right, and ductus. For examination of aortic arch, I prefer slow flow imaging. It's very informative. We can see 2 arches, aortic arch and ductal arch, from early steps of the pregnancy, from 30. It's good choice for examination of arch. And now I will talk about the asymmetry. It's clear, okay? 14 weeks, 4-chamber, asymmetric 4-chamber view. I was in very high stress in this case because all other vessels, great vessels, flow was absolutely normal. But something wrong here. Do you see? Here, small vessel. It's not usual vessel in every single exam. Are you agree with me? And here you can see the vessel coming upright and connection with left subclavian. And this case of intercostal vein, superior intercostal vein, in this case it was a preload more than usual to the right side, and 4-chamber was asymmetric, not because small left side, because big right side. The baby was born absolutely normal, but emergency unit and the cardiologist do follow up, but baby now absolutely normal. Prepare operation room, the possibility of something with the aorta, but nothing. So it's an example of normal baby with early appearance of asymmetric 4-chamber with additional vessel to the right side. Reason for ventricular asymmetry may be with large right ventricle, aortic coarctation, hypoplastic left heart, physiological state, the 3rd trimester, trisomy 21, interrupt aortic arch, AVSD, total anomalous pulmonic vein return, persistent left superior vena cava, double right outlet, absent pulmonic valve syndrome, Epstein anomaly, and problem of the left heart, vein of Galen, tricuspid insufficiency. The cardiac asymmetry with the right predominance. Right bigger, left smaller. Borderline asymmetry of the fourth chamber in 15 in 5 days, very subtle. But something wrong here. You can see here flow from the left to the right through VSD and absent aorta in the three vessels view. It was severe aortic coarctation with VSD. The VSD protect to the left ventricle from the hypoplastic left heart. Okay? Slow flow, you can see here, very small aorta, dysmorphic and small. Sagittal plane, it was ductal arch. In the axial plane, main pulmonic artery, left pulmonic artery, right pulmonic artery. On the sagittal plane, just this vessel, this is aortic arch. Dysmorphic, small. Diagnosis, early appearance of coarctation with asymmetry of fourth chamber. And there you can see reverse flow in the small aorta. Let's move to the Schwann complex. Schwann complex, it's problem of all left valves. Mitral valves, parachute type, aortic valve, and coarctation with mitral stenosis. Okay? This is a case G1, 22 weeks, normal nuchal. Early anatomical scan was normal in 15. Second trimester anomaly scan, suspected heart anomaly. What we see here, ballooning dilatation of the left ventricle, high echogenicity of endocardial fibroelastosis, abnormal movements of the muscle of the left ventricle, high echogenicity and small aortic valve, and abnormal movements of the mitral valve. Again, abnormal four-chamber view, endocardial fibroelastosis, abnormal opening of the mitral valve, and absent flow of mitral valve. Sagittal view of aortic coarctation by slow flow imaging. You can see here abnormal aorta, coarctated and dysmorphic. The theory behind coarctation development is extra tissue in the place of connection, aortic arch with ductal arch. Like this, but it's normal. Sometimes it's much more prominent. Aortic coarctation in 16. You can see here normal relationship between two arch, aortic arch and ductal arch. This is the case 15 or 16. Normal relationship, aorta, the vessels coming to the neck, connection, distal part of the ductus venosus, ductus arteriosus, sorry. And in this case, you can see asymmetry of the heart and abnormal relationship. This is aorta, smallish than ductus. And the first step in this diagnosis things was asymmetry of the fourth chamber. Again, hypoplastic left hearts. In the 14, 15 weeks, we have two good signs. The apex built by right ventricle, like this, and reverse flow in the aortic arch. Small aorta and reverse flow. Two good signs for decision that it's a case of hypoplastic left heart. This is a case of late appearance of coarctation in 14 and 2. As said Professor Nicolaides, just abnormal men like Rui and me. See here asymmetry of the fourth chamber. Very, very subtle, something. I not was sure about it, but I said, you need follow-up by cardiologist. Normal aorta. And now, this is 27 weeks. You see here asymmetry in the TVT, aorta, and you can put your eyes in this area. The left subclavian coming in the place far away from the left carotis. Asymmetry in almost 30, prominent asymmetry. It's normal. Left subclavia, left carotis, normal relationship. Again, you can see here, distance between two vessels. It's good sign for coarctation of aorta. This is a normal, okay? Something wrong with the computer. Mm-hmm. Mm-hmm. Okay. The next case, only finding in this fetus was asymmetry of fourth chamber. Very subtle, very small. The patient did amniocentesis. It was T21. Interrupted aorta, we know three types of interrupted aorta behind the right, left. Let's move in the case. Asymmetry of fourth chamber and TVT in 80 weeks. Pulmonic artery, small aorta. But there, on the sagittal plane, with use of power Doppler, we can see here interrupted aorta. The baby was born with interrupted aorta and died 1 day after delivery. slow flow imaging. This is a place of interruption. All this, the ductus. Now, I will talk about asymmetry with the left predominance. The reason for this situation, tetralogy, absent pulmonic valve syndrome, double right outlet, Epstein, TJ, corrected transposition, and right isomerism. We can see here large right ventricle and small left ventricle. Slow movements. It's clear, yes? It's not so sophisticated. On the axial plane, one rib, asymmetry. Normal aorta. Normal aorta coming from the left without VSD. Whoa, 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 whoa. Okay. It was a case of early appearance of pulmonic artery with backflow. The presentation. Okay. Okay. Anyway, you can see here pulmonic artery with backflow. Early appearance of pulmonic stenosis with pulmonic insufficiency, with backflow through the valve. This is a case of tricuspid atresia. We can see flow just on the left side, nothing through the tricuspid. The big vessel is aorta. And something interesting, you can see here, backflow in the pulmonic. This is pulmonic, it's not aorta. On the sagittal view, the same aorta and backflow in the pulmonic and ductus. Actually, it's a ductus. This is a case with a difficult for diagnosis. You see here asymmetry. Are you agree? Yes, it's clear. What do you think? It's aortic coarctation? Maybe. Return of the pulmonary veins are correct. Are you agree with me? It's coming to the left. Two reasons I know for huge coronary sinus. It was coronary sinus, dilated coronary sinus. One of them, the persistent left superior vena cava, entry to this coronary sinus, and the second one, intracardiac total anomalous pulmonic vein return. Is the three vessels, I not saw persistent left superior vena cava, so I have second option. It's normal TTV, it's normal TTV2 without persistent left superior vena cava. The answer is here. You see the red flow close to the valves. It's not foramen ovale, it's not flow from the inferior vena cava through Eustachian valve. It's total anomalous of pulmonic vein return, intracardiac. So it was asymmetric heart with heart predominance, huge coronary sinus, functionally narrowed aorta. It's an important issue. It's not coarctation. It's emergency situation, and delivery must to be in 30 centers with cardiac surgery. It's a relative rare case. It's true double inlet left ventricle. We can see here two valves into the single ventricle. Two flows, two valves, single ventricle. It's not huge VSD, not something else, true single ventricle. In many cases with this situation, we can see pulmonic stenosis. I don't know why. I have my theory, but not batuach that I right. Very rare case, non-compaction cardiomyopathy with interrupted aorta. The lady referred the first time to examination during pregnancy. 27 weeks, absolutely absent left ventricle. And aorta was interrupted. And this happy case, severe ventricular asymmetry. The first screen in 15, not something special to me. Normal flow in every compartment of the heart and the great vessels. 22 weeks, subtle asymmetry, but not something prominent. Normal aorta, normal aortic arch, normal flow from the aortic valve, through aortic valve and pulmonic valve. And this 37 weeks. Catastrophe. I was in high stress with this patient. What's up with this heart? But flow was normal, size of the aortic valve was normal. And after delivery, baby was absolutely normal. After closing of the ductus and foramen ovale, the heart was normal without asymmetry. Two reasons for this situation. The first, tortus ductus arteriosus, because high pressure in afterload, and aneurysmal dilatation of the flat foramen ovale, the high pressure, the preload. And both of them was here, there in this baby. After delivery, absolutely normal heart. Thank you.